Thank you, Dr. Surekha and the chairpersons. Thank you, Dr. Garg and the entire organizing team for asking me and allotting this topic to me, decoding idiopathic or primary or idiopathic. I've called it as idiopathic generalized epilepsy. I was just looking up the definition of decoding. So decoding is making intelligible something which is in a coded form. So everyone here is really very intelligent. So that's something I cannot do. And what I will do is just take you through some of the more controversial and some of the little known aspects of idiopathic generalized epilepsy in about the 20 minutes that I have. So, ladies and gentlemen, just look at this EEG. And can I have a pointer? Is there a pointer, please? Right. Right. Okay. Uh, yeah. So what do you think this is? There is a sharp wave, there is a slow wave, and there is something like a spindle. So whenever you have a combination of a sharp wave, a slow wave, and a spindle, you think in terms of a K complex, right, in sleep. And this is another same EEG of the same person. So you can see a K complex, but this looks a little suspicious. But then this is also a sharp wave, a slow wave, followed by a spindle-like activity. So question is this a K complex or is this epileptiform? Now this is a little more difficult. So there is a sharp wave, slow wave, spike and slow wave, and then again followed by a spindle, right? So whenever you have K complexes, the teaching is that you should always underreport EEG, and K complexes are should be reported as K complexes as sleep markers, and we should not make the mistake of calling K complexes or labeling them as spike and wave discharges. But there is something known as epileptiform K complexes, and this is something that happens only in idiopathic generalized epilepsy. What basically happens is during K complexes, there is a microarousal, and that microarousal often precipitates these discharges, and this phenomenon is known as dysrhythmia. Extremely rare. I've seen 2 patients with epileptiform K complexes, but still the message should be underreport EEGs, and before you label K complexes as epileptiform, you really need to think a lot, right? But this happens in idiopathic generalized epilepsies. Look at this EEG. This is a different patient. So this is left parasagittal, right parasagittal, left temporal, right temporal. So what looks like here is a spike and wave discharge, and it seems to be coming from the left side, right? Next page, spike and wave discharge, and this time seems to be coming from the right side. Another few pages later, you have a generalized spike and wave discharge, right? And here's another page, very typical generalized spike and wave, right? So in idiopathic generalized epilepsy, you can frequently get these kind of focal discharges, right? And the discharges can be asymmetrical, they can be focal. And obviously the differential diagnosis here is secondary bilateral synchrony. And how do you differentiate? You can have a lead-in in both the conditions, but lead-in in secondary bilateral synchrony, which there is a focal lesion, a focal spike, a focal epileptogenic zone, which then generalizes. The lead-in is generally more than 2 seconds. The focal spikes are similar in morphology to the bisynchronous discharges. They're usually unilateral, unifocal, one focus, right? As opposed to the EEG, which I just showed, they could either be on the right side or the left side. And then the underlying MRI is normal, but it is abnormal in someone who has secondary bilateral synchrony. Doesn't show very well, but this is secondary bilateral synchrony where you have this focal discharge for a very long period of time and then becomes bilateral synchronous. So besides focal discharges or asymmetric discharges, you can also get focal semiologies in idiopathic generalized epilepsy. And there are a number of papers and a number of signs which we typically attribute to focal epilepsy, which can be observed in generalized epilepsies. And there is an increasing trend, particularly in Western countries. I don't very often get long-term EEGs or video EEGs in patients with idiopathic generalized epilepsy. If the EEG shows idiopathic generalized epilepsy, that's it. I would probably stop there. But there is this increasing diagnostic trend that more and more patients with idiopathic generalized epilepsy or supposed idiopathic generalized epilepsy end up in the epilepsy monitoring unit, and they can identify all these focal semiologies in idiopathic seizures associated with idiopathic generalized epilepsy. But while you can get all these focal semiologies, you can get these focal discharges, focal interictal discharges. A focal ictal onset is certainly rare on the EEG. And this is the subject of this recent paper from this group in Denmark, where you could have focal semiologies, you could have asymmetric ictal discharges, you could have focal interictal discharges, but a focal ictal onset is decidedly rare. So, what is this idiopathic generalized epilepsies? And you know that sometime back, I think it was 2010 classification, or I don't remember the dates, was this huge move to convert from idiopathic generalized epilepsy to genetic generalized epilepsy. And there were a number of proponents as well as opponents who wanted the name idiopathic generalized epilepsy to be discarded, and it should in future be called as genetic generalized epilepsy. And that was the genetics revolution. Everyone thought that genetics is here, and since genetics is here, it's going to make a huge impact on diagnosis, on treatment, and everything. So we should call it as genetic generalized epilepsy. But somehow the term idiopathic generalized epilepsy stuck and is still used. And the term genetic generalized epilepsy is becoming more and more unpopular. But there is this paper recently, right? And this diagram from this paper, which I've taken from the paper in the earlier, which I referred to in the earlier slide, clearly depicts the status of idiopathic generalized epilepsy within genetic generalized epilepsies, right? So the idiopathic generalized epilepsies are 4: childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures on awakening or alone. But then genetic generalized epilepsy includes a whole lot of other syndromes. Epilepsy, this is earlier called the Douze syndrome, epilepsy with eyelid myoclonia, epilepsy with myoclonic absences. This is Jeevan syndrome. This is was described by Tassinari, so Tassinari syndrome, and so on and so forth, right? And the hallmark here is that there is developmental slowing, regression, standstill in association with very difficult to control epilepsy. So, what are the seizure types in idiopathic generalized epilepsy? You can actually get only three types of seizures: generalized tonic-clonic, myoclonic, and absence. In genetic generalized epilepsy, on the other hand, you can get many other different types of seizures: atypical absence seizures, eyelid myoclonia with absences, I'll show you an example, myoclonic absence seizures, I'll show you an example, tonic, atonic, and myoclonic, atonic, which were previously called as astatic seizures. Right. So this is a typical, see for yourself, in children particularly, very young children. It's very difficult to do hyperventilation, but then hyperventilation is very useful to elicit these kind of seizures. Right. I think there is a sound there, but that's all right. The picture speaks better. You can see she's standstill, eyes move up. There is some clonic movements of the eye, can sometimes also be associated with clonic movements, retropulsion of the head, very brief, and no postictal confusion. As opposed to this child, so the earlier seizure was very characteristic onset, very characteristic offset, right? Here it's difficult to make out. The child is writing, then becomes a little still, looks up slightly, and then she gets back to her activity. So this is the difference here from the earlier seizure, is the onset and the offset were not very characteristic. So this is atypical absence, which you would get in, for instance, in Lennox-Gastaut syndrome. I'm sorry, this, right, it's working. Right, I thought it, right? So this was also, the child was being made to hyperventilate, but just towards the end, she had an absence seizure, but you notice that there were some clonic movements of the upper limbs as well as the head, right? So that is very characteristic. In absence seizures, you can get few clonic twitches of the eye, but no clonic movements of the shoulders or the upper limbs, as you saw in this video. So this becomes myoclonic absence seizures, right? It's important to recognize this because two things. With the onset of seizures in childhood, there is intellectual deterioration, standstill, and so on and so forth, which occurs. And secondly, the seizures are extremely difficult to control, right? They do not respond to the usual treatments for childhood absence epilepsy, ethosuximide, valproate, lamotrigine, and it's a real challenge trying to treat these patients. Described by Tassinari and therefore known as the Tassinari syndrome. And then you have eyelid myoclonia, and this is the EEG signature of eyelid myoclonia. This is an eye closure, and this is basically a form of photosensitivity. It elicits eyelid myoclonia, it can elicit absence seizures, and these are again really very difficult to control, right? And this is something again very typical, right? So this boy is trying to provoke seizures. It's known as the sunflower syndrome. So these are self-induced or self-generated seizures, again very typical. So now I want you to look at this EEG of another child, I'll tell you the age. When you look at EEG, you need to know the age and the state of the patient. You can see that in the posterior head regions, there is a lot of slowing, right? Both sides symmetrical. It occurs in a 5-year-old. This is associated with one very characteristic idiopathic generalized epilepsy syndrome. And this is the sleep EEG, where you get these short bursts of polyspike wave discharges. This is not polyspike, but you can get polyspike wave discharges. And this is the awake EEG, typical 3 hertz spike and wave discharges. So in children, you get occipital slow wave, rhythmic slow, OEDA, and that is often seen in children with childhood absence epilepsy, and that is something you should always think about. A question often asked is, what is the role of genetics in idiopathic generalized epilepsy, and what kind of genetic test do I need to do in someone in whom I've made a diagnosis of idiopathic generalized epilepsy? So, although there is a high rate of concordance, we need to understand that idiopathic generalized epilepsies are rarely monogenic. There are about a handful, 4 or 5 good examples of monogenic idiopathic generalized epilepsies. Most of the idiopathic generalized epilepsies are polygenic, where there are hundreds to thousands of genes, each with a very small effect, and when they all add up, the individual presents with idiopathic generalized epilepsy. So therefore, since it's polygenic and there are hundreds and thousands of genes, genetic testing is not applicable usually in idiopathic generalized epilepsy. That's my policy, although this particular paper suggests that you should do exome sequencing or whole genome sequencing if there is a positive family history or if there are these associated features. One more slide. I think my time is up. I just heard that. So I will stop after this slide. But then there is this concept of drug resistance in idiopathic generalized epilepsy. We generally believe that idiopathic generalized epilepsy, the seizures are quite easy to control, pretty much easy to control. But these are figures from different publications. The frequency of drug resistance, particularly in GME, is nearly to the tune of 30%. And these are some of the risk factors. If there's a very early onset, the presence of absence seizures. That could be either childhood absence epilepsy going on into JME, evolving into JME, or JME in which there are absence seizures in addition to the myoclonic seizures and the generalized tonic-clonic seizures. So that is a sign of drug resistance. And then all these things and the presence of psychiatric comorbidities. I am not going to talk about these two, but this is my concluding slides. And ladies and gentlemen, there is a myth. People generally believe idiopathic generalized epilepsies are easy to control. In fact, as I said, and as I presented some of the literature, evidence from literature, 30%, 1/3 of them can be drug resistant. It is often believed that people with idiopathic generalized epilepsy do not have any comorbidities, but comorbidities can occur. This is typical personality of JME, which you should recognize, right? Irritable, agile, so that's, unable to make decisions, right? Undecided person. So comorbidities are common in idiopathic generalized epilepsy. We believe that SUDEP does not happen in idiopathic generalized epilepsies, but it does. And there are now large series which tell us that SUDEP can occur in idiopathic generalized epilepsies. So we need to discuss SUDEP, because these are generalized seizures. And remember, what is the risk factor for SUDEP? Someone who has a generalized tonic-clonic seizure, right? So if an adolescent is non-adherent, goes on a parties, awake the whole night, lots of alcohol, has a seizure, it's going to be a generalized seizure. And generalized tonic-clonic seizures are the main risk factor for SUDEP. So SUDEP happens in idiopathic generalized epilepsy and should be discussed with patients. Thank you.